Sorry. Okay. These patients' intermittent cough, chest tightness, and shortness of breath, worse at night, are hallmark symptoms of asthma. Asthma is the most common pulmonary disorder encountered during pregnancy. Roughly one third of the cases improve, one third are stable, one third is worsen. Patients with a history of severe or poorly controlled asthma are prone to developing unstable disease during pregnancy, typically worsening in second trimester. The immunologic and endocrine changes. The immunologic and endocrine changes during pregnancy can also rekindle previously resolved childhood asthma. Asthma presents similarly in pregnant and non-pregnant patients. Cough, wheezing, dyspnea, chest tightness. Symptoms are typically intermittent and may be exacerbated by weather changes, especially cold, allergen, infections, or exercise. They usually worsen at night, potentially due to circadian hormonal variation, low epinephrine, glucocorticoid signaling causing reduced anti-inflammatory effect, or to environmental factors, dust mite or pet hair in the mattress. Wheezing may be absent outside of acute attack. Asthma control is essential for avoiding maternal and fetal complication, preterm delivery, low birth weight, antenatal hypoxia. Most therapies are safe and generally involve inhaled short-acting beta-agonist albuterol for acute symptoms. Inhaled corticosteroids are required daily for persistent asthma, and oral corticosteroid prednisolone may be required for acute exacerbation. Gestational asthma can be confused with dyspnea of pregnancy, a common physiologic cause of shortness of breath, air hunger, likely due to progesterone-induced stimulation of the medullary respiratory center. Although it worsens during the second trimester, dyspnea of the pregnancy is persistent rather than intermittent and not associated with diurnal variation. It would not explain these patients' cough and chest tightness. Okay. Okay, this patient with type 2 diabetes mellitus has acute pyelonephritis, fever, chills, flank pain, costovertebral angle tenderness, pyuria, bacteria complicated by septic shock, a type of distributed shock. Septic shock is characterized by peripheral vasodilatation that can lead to profound hypertension. As a result, vasopressor, which increase systemic vascular resistance, are often necessary following fluid resuscitation to restore adequate mean arterial pressure. Norepinephrine, a first-line vasopressor for treatment of septic shock, acts on both alpha and beta 1 adrenergic receptor and its alpha 1 agonist properties produced potent vasoconstriction. These vasoconstriction increases mean arterial pressure, provide circulation, provide circulation to the critical organs, brain. However, it also decreases perfusion to the peripheral structure, such as distal disease. The resulting distal ischemia, which is typically bilateral and symmetric and can lead to tissue necrosis, dry gangrene if prolonged, as seen in this patient. In a similar fashion, vasopressor-induced vasoconstriction can negatively impact the intestine, causing mesenteric ischemia, and kidneys, causing renal failure. Okay. Yes. Look at the A gradient. Normal A gradient has, according to first aid, normal A gradient has two differential like hypoxia and hypoventilation, and increase AA gradient has three differential VDR like VQ mismatch, diffusion limitation, and right to left shunt. So if you find a case with hypoxemia, like normal oxygen level should be like near about 60 to 80 or near about 100 normal PaO2 level. If PaO2 is less than 60 millimeter of mercury, if PaO2 is less than 60 millimeter of mercury, less or equal 60 millimeter of mercury, then look at the elevated AA gradient, alveolar and arterial gradient. If alveolar and arterial gradient is not elevated, no, then two differential like either it is hypoxia or hypoventilation. Um, Elevated AA gradient, no. If elevated carbon dioxide, if carbon dioxide is elevated, in here carbon dioxide is 63, so carbon dioxide is elevated, so it is alveolar hypoventilation. And alveolar hypoventilation has two causes like peripheral neuromuscular disease and central opioid and obesity hypoventilation syndrome. And elevated PaCO2, no. Elevated PaCO2, no. Then low inspired oxygen, low PiO2, low inspired oxygen. Cause is high altitude, low partial pressure or low atmospheric pressure, high altitude, and low FiO2 like asphyxia. Okay, if AA gradient is elevated and it is yes, it corrects with 100% oxygen, yes, then it is either VQ mismatch or diffusion limitation. VQ mismatch may be focal pneumonia or segmental pulmonary embolism, and diffusion limitation is ILD and emphysema. If it does not correct with 100% oxygen, no, right to left shunt, intrapulmonary shunting, or intracardiac true anatomic problem. Intrapulmonary shunting like shunt effect, or true anatomic like intracardiac. Okay. This patient has post-operative respiratory acidosis, pH less than 7.35, PaCO2 more than 40, and hypoxemia, low PaO2. Low PaO2. Okay. With a normal AA gradient, low PaO2 with normal AA gradient, which is best explained with alveolar hypoventilation. Several factors can contribute. Several factors can contribute to postoperative hypoventilation, including limiting thoracic expansion, central respiratory depression, and central respiratory depression due to anesthesia and opioids, hydromorphone. In addition, patients with obesity are particularly prone to hypoventilation because of restricted diaphragmatic excursion at baseline. The AA oxygen gradient, the AA oxygen gradient, which compares the expected partial pressure of alveolar oxygen PaO2, which cannot be directly measured and is estimated based on the partial pressure of the inspired oxygen PiO2 and minute ventilation with PaO2, which is directly measured via arterial blood gas analysis. A normal AA gradient 4 to 15 millimeter of mercury indicates that oxygen transfer between the lungs and the bloodstream is intact, whereas an elevated gradient suggests disruption of the oxygen transport. In hypoventilation, minute ventilation tidal volume and respiratory rate is reduced, resulting in reduced PaO2 with oxygen transfer intact. This reduced PaO2 leads to directly reduced to P PA like arterial reduced to arterial oxygen, causing hypoxemia with a normal A gradient. The other major cause of hypoxemia with normal A gradient is reduced inspired oxygen, like high altitude. Okay. Infiltrate the peripheral right. Maybe G. Can you hear me? Okay. Okay. Pulmonary contusion. Pulmonary contusion presents less than 24 hours after blunt thoracic trauma. Tachypnea, tachycardia, hypoxia, tachypnea, tachycardia, hypoxia, rales or decreased breath sound. Most sensitive CT scan most sensitive or chest X-ray with patchy alveolar infiltrate, not restricted by anatomic border. Management is pain control, pulmonary hygiene, incentive spirometry, chest physiotherapy, and supplemental oxygen and ventilatory support. Supplemental oxygen and ventilatory support. This patient with blunt thoracic trauma. This patient with blunt thoracic trauma, right chest wall bruising, has worsening tachypnea and hypoxemia, and ipsilateral irregular infiltrate on chest X-ray. Signs for concerning pulmonary contusion. Pulmonary contusion represents lung parenchymal bruising due to transmitted kinetic energy with resulting alveolar hemorrhage and edema. It is frequently associated with rib fracture but may occur in their absence, especially in children whose more elastic chest wall can transmit more kinetic energy without fracturing. Manifests of pulmonary contusion include tachypnea, hypoxemia, and decreased breath sound due to alveolar infiltrate. Because clinically significant alveolar edema may take hours to accumulate, the initial chest X-ray is often negative. CT scan more sensitive or repeat chest X-ray, as in this patient, may be necessary to reveal patchy, irregular alveolar infiltrate. Char- Characteristics of pulmonary contusion. Because these infiltrate reflex alveolar damage in the lung tissue adjacent to the injury site. Right peripheral lung in this patient, they are typically non-lobular, not restricted by anatomic landmarks. Management of pulmonary contusion is supportive, involves pain control, pulmonary hygiene, and respiratory support. Sorry? Yes. Look here, like we missed this part. Premature formula. She has been receiving enteral feed via NG tube with premature formula. So premature formula feeding can cause necrotizing enterocolitis. Okay, and she is premature baby. So premature baby having premature formula enteral feeding can cause neck. Okay, first box are pathogenesis, gut mucosal wall invasion by gas producing bacteria, and intestinal inflammation, necrosis. Risk factor is prematurity, very low birth weight, less than 1.5 kg, and enteral feeding. Non-specific apnea, lethargy, vital sign instability. Non-specific is apnea, lethargy, and vital sign instability, gastrointestinal abdominal distension, feeding intolerance, and bilious feeding intolerance, bilious blood is X-ray show pneumatosis intestinalis, air in the bowel wall, pneumatosis intestinalis, and pneumoperitoneum, free air under the diaphragm, free air under the diaphragm. Complications sepsis, DIC, late stricture and short bowel syndrome, late stricture and short bowel syndrome. This preterm these preterm infants increasing apnea and abdominal distension are concerning for necrotizing enterocolitis, a life-threatening condition characterized by intestinal inflammation and necrosis due to gas-producing bacteria at a very low birth weight neonate receive enteral feeds, particularly with formula, are at decreased risk for necrotizing enterocolitis. A high degree of suspicion is required in these infants because initial findings may be subtle but can lead to rapid clinical deterioration. Presentation can occur weeks after birth, is non-specific including apnea, lethargy, feeding tolerance, vitals and instability, hypothermia. The abdomen is typically distended and can become tense and erythematous. Lab evaluation is also non-specific, but the lymphocyte count may be normal, low or elevated. Notably, thrombocytopenia and metabolic acidosis are associated with advanced cases. The next step in evaluation of suspected necrotizing enterocolitis is abdominal X-ray, where you may see pneumatosis intestinalis, pneumatosis like air in the bowel wall. Pneumatosis intestinalis is a diagnostic. Neck complicated by intestinal perforation reveals pneumoperitoneum, free air under the diaphragm. On X-ray is an indication of surgery. Okay. Okay, this patient with COPD and acute onset shortness of breath, hypoxia, and unilaterally decreased breath sound. Unilaterally decreased breath sound likely has secondary spontaneous pneumothorax. Secondary spontaneous pneumothorax occurs in patients with known lung disease, COPD, cystic fibrosis. Other common manifestations include chest pain, hyperresonance on percussion, cigarette smoking, markedly increase the risk of pneumothorax, chronic obstruction of alveolar sacs. Chronic obstruction of the alveolar sac uh, leads to formation of the large alveolar blebs, which can eventually rupture and leak into the pleural space. Diagnosis of the pneumothorax is based on chest X-ray, which demonstrate visceral pleural line beyond which no pulmonary markings are present. Tracheal deviation occur but is rare, more commonly seen in patients with primary spontaneous pneumothorax. Management depends on the size of lesion and the clinical status of the patient and ranges from obstruction with supplemental oxygen and emergency tube thoracostomy. Yes. Although rapid bronchial occlusion results in extensive atelectasis, can result in similar symptoms: chest pain, dyspnea, hypoxia. This patient does not have risk factor for obstructive atelectasis such as a history of foreign body aspiration, malignancy, or severe pneumonia. Moreover, extensive atelectasis frequently causes tracheal deviation towards a collapsed lung. And B. Diffuse bronchial obstruction is seen in acute COPD exacerbation due to increased production of purulent sputum. Lung examination reveals diffuse bronchi and wheezing, and symptoms tend to occur more gradually. Acute causes of pulmonary edema, acute myocardial infarction, acute respiratory distress syndrome most commonly result in symmetric examination finding bilateral coarse cracking. Transudation of the pleural fluid can commonly occur in patients with heart, liver, and renal failure. The presence of fluid in the pleural space is characterized by dullness to percussion with decreased breath sounds over effusion, usually in the lung field, but the symptoms are typically slower to evolve. Patients with COPD are increased risk for pneumonia due to chronic inflammation and chronic use of corticosteroids. However, patients with pneumonia typically present with fever, productive cough in addition to chest pain and breathlessness. Okay. Okay. This patient who was toilet trained, this patient who was toilet trained now wets the bed because of secondary aneurysms. In the context of disrupted sleep with loud snoring, daytime fatigue, tonsillar hypertrophy is likely related to obstructive sleep apnea. As in adult, OSA in children is a sleep disorder in which episodic upper airway obstruction occurs. In adults, obstruction is usually caused by obesity, whereas in these young children, it is often due to adenotonsillar hypertrophy. The obstruction results in difficulty breathing, disrupted sleeping, snoring, restless sleep, and apnea. Daytime symptoms in children may include sleepiness, as in this patient, or manifest as inattention, learning difficulties, and behavioral problem. In addition, nighttime symptoms in children may also include parosmania, parasomnias, and aneurysms. The mechanism of aneurysms is unclear, but it may be related to elevated levels of B-type natriuretic peptide seen with OSA, possibly due to intermittent obstruction causing increased cardiac volume and pressure. Untreated, okay, untreated OSA in children, as in adult, can result in cardiovascular complications likely related to disruption of the autonomic neural and due to sympathetic activation during periods of hypoxia. Cardiovascular consequences can include systemic hypertension, tachycardia, systemic heart change, structural heart changes, right or left ventricular hypertrophy, pulmonary hypertension, although the latter is more commonly associated with pediatric vessel. Okay, maybe carb 65. Mm, okay, respiratory rate is higher. 1.5 age more than 60. Um, blood pressure not that high. Oh, wait, how much point he has got with carb 65? Carb 65 for patient with Okay, CURB65, age 65, 1 point. Does he has confusion? No. He has confusion? Okay, then 2 point. Uh, Respiratory rate is more than, okay, 24 higher. Okay, then I think that it is inpatient admission. Okay, look at the curve 65 criteria. So curve 65 criteria, age more than 65, 1. Blood pressure 90/60. Blood pressure criteria does not match, but respiratory rate, he has confusion, so he got 2 point. So as he has got 2 points, so admit to the hospital. If he is getting 3 or more than 3 point, then ICU. And if there is 0 point, 0 to 1 point, then it is outpatient management. That's carb 65. So if somebody has pneumonia and age is more than 65, we need to do carb 65. Okay. Yes. Okay. Recommended therapy, community for CAP, community acquired pneumonia, for healthy patient, amoxicillin or doxycycline, and for outpatient management and comorbid condition like diabetes, malignancy, fluoroquinolone or beta lactam drug with macrolides. Okay. An inpatient non-ICU fluoroquinolone or beta lactam plus macrolide. An inpatient ICU beta lactam plus macrolide or beta lactam plus fluoroquinolone. Sorry, in no, I do not know. Okay. Okay, this patient with non-productive, this patient with productive cough, fever, leukocytosis, mild hyponatremia, and right lower lobe infiltrate, has community acquired pneumonia. This patient with community acquired pneumonia risk stratified using the pneumonia severity index or CARB 65 to help to guide the treatment, and treatment location, home, medical floor or IC. This patient has scored 3 on CARB 65 criteria. Like age more than 65, confusion, and BUN. Is there any BUN? Okay. BUN is higher. Okay. BUN is more than 20. So this patient needs hospitalization on the medical floor. Sputum culture and blood culture should be sent to identify the organism, and empiric treatment with beta lactam plus macrolide like ceftriaxone plus azithromycin should be initiated. This combination treats the most common bacterial community acquired pneumonia, streptococcus pneumoniae, Haemophilus influenzae, Legionella, Mycoplasma. Although fluoroquinolones, levofloxacin, moxifloxacin that target the respiratory tract organism can also used for CAP, community acquired pneumonia, in inpatient setting. This class of medication is generally avoided and in elderly, and in elderly patient due to increased risk of Clostridium difficile infection, tendon rupture, and aortic dissection. Mm, So fluoroquinolone is avoided in elderly patients due to C. diff infection, tendon rupture, and aortic dissection. Okay, okay. It is respiratory failure in asthma. Okay, look at the box first. Absent or minimal wheezing, poor air movement, silent chest, accessory muscle use, altered mental status, ABG show poor ventilation, PaCO2 is high and pH is low, poor ventilation, poor oxygenation, lactate is high due to transient increase due to muscle work of breathing type A or beta agonist induced type B. Potassium transient due to potassium transient decrease due to beta agonist and respiratory alkalosis. Management nebulized albuterol, aniprotropium, IV corticosteroid, IV magnesium, short trial, less than 2 hours of NIPPP, and low threshold for intubation and mechanical ventilation. These children's presentation is consistent with bronchospastic airway disease, wheezing, hyperinflation triggered by recent viral upper respiratory tract infection. Given the severe bronchospasm, management is similar to severe acute asthma. Patients are treated with multiple agents, inhaled with or without IV beta agonist, inhaled antimuscarinic antagonist, IV magnesium, systemic corticosteroid to achieve maximal bronchodilation. When severe inflammatory obstruction is present, pharmacologic reversal of bronchospasm requires hours to days for full effect. So patient must be closely monitored for respiratory deterioration in the interim. A time limit less than 2 hours of maximum trial of non-invasive positive pressure ventilation to assist work of breathing may be considered as a bridge of recovery despite a trial of non-invasive positive pressure ventilation. This patient alarming signs of deterioration, including agitation, altered mental status, absence of wheezing, silent chest due to bronchospasm. In addition, acute asthma normally cause respiratory alkalosis, high pH, low PaCO2 due to increased respiratory drive, and elevated or even inappropriately normal PaCO2 as in this patient is concerning for respiratory failure due to respiratory muscle fatigue. Therefore, the next step is performing endotracheal intubation and initiating invasive mechanical ventilation. Intubation should be ideally performed in a proactive or controlled manner. No improvement after a time-limited trial of non-invasive positive pressure ventilation. Delayed crash intubation is associated with greater morbidity and mortality, cardiopulmonary arrest, anoxic brain injury. Continued observation on non-invasive positive pressure ventilation would be appropriate only for a patient with clear improvement. Okay, sorry. It is foul smelling, looks like uncomplicated. Okay, this elderly patient with Alzheimer dementia likely has aspiration pneumonia complicated by pleural effusion or empyema. The foul smelling the foul smelling fluid is highly suggestive of infection of the anaerobic flora, which is typically polymicrobial infection, Streptococcus intermedius, Fusobacterium prevotella, and bacteroides. Empyema pass in the interpleural space represents advanced progression of a complicated parapneumonic effusion. Initial presentation may be similar to uncomplicated pneumonia, fever, cough, shortness of breath, pleuritic chest pain, leukocytosis. However, patients with empyema often have weight loss, and a relatively gradual presentation week or more. The presentation of anaerobic empyema may be especially prolonged 2 to 3 weeks. Accompanying pleural effusion is often suggested. Physical examination, decreased breath sound, dullness to percussion, and confirmed by chest X-ray where the effusion may appear free-flowing, early empyema, or relatively fixed with evidence of location. More advanced thoracosynthesis and pleural fluid analysis confirm the diagnosis. Turbidity suggests pus and putrid or foul-smelling pleural fluid is diagnostic of the anaerobic empyema, as aerobic organisms do not produce the same pungent sulfur-containing compounds as anaerobic. Yes, Mycobacterium tuberculosis is a rare case of empyema. It may complicate the reactivation of the latent TB and be associated with fever, cough, weight loss. However, it is not expected in patients with a lower lobe pneumonia. Reactivation usually affects the upper lobe, typically cause symptoms over prolonged period, sometimes month. In addition, Mycobacterium tuberculosis is highly aerobic and is not expected to cause foul-smelling pleural. And streptococcus pneumoniae is among the most common causes of community-acquired empyema. Staph aureus is the common cause of both community-acquired and hospital-acquired empyema. Pseudomonas aeruginosa is an occasional cause of hospital-acquired empyema in patients with cystic fibrosis. Empyema caused by these organisms does not produce the foul smell associated with anaerobic organism. In addition, the presentation is typically gradual, typically less gradual, a week rather than 2 to 3 weeks of symptoms than empyema caused by anaerobic organism. Okay.